بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد المرسلين. اللهم لا سهل إلا ما جعلته سهلا، وأنت تجعل الحزن إذا شئت سهلا. اللهم اجعل أمرنا هذا سهلا سهلا. أما بعد، critical care medicine has now established itself as a standalone super specialty in our region and all over the world. Intensive care physicians need to have a strong knowledge of mechanical ventilation, hemodynamic monitoring, airway and trauma management, along with comprehensive knowledge in internal medicine, anesthesia, pulmonology, cardiology, nephrology, and infectious disease. Nowadays, it's so clear for everyone how much important to have good number of qualified physicians who can take care of the most ill patients. So it has become essential for all intensivists and frontline care provider to keep them updated with the latest advances in the field. Today, it's a big honor for all of us that we are starting the critical course online essential course in cooperation with Qatar Society of Critical Care Medicine and the School of Medicine in Islamic University of Gaza. This 5-day course contains 10 lectures, home messages, open discussion, and 2 workshops. So it will give you important basic knowledge. You will hear important tips and points from multinational experts, and this will encourage you to read more, to build up your basic and clinical knowledge, to save lives. قال تعالى: ومن أحياها فكأنما أحيا الناس جميعا. On behalf of all audience from Palestine, let me welcome our lecturer from Qatar for today, Dr. Ibrahim Fawzi Hassan, Head of Qatar Critical Care Society 2019. He's a Senior Consultant in Critical Care and Pulmonology Medicine. He's an ECMO Program Director in HMC. He's Associate Professor of Clinical Medicine of Weill Cornell Medical College, New York. Also, it's my pleasure to welcome Dr. Ahmed Labib Shihata. He's a Senior Consultant in the Medical ICU, Hamad General Hospital. He's an Assistant Professor of Clinical Anesthesiology, Weill Cornell Medical College. We cannot forget to thank our colleague in Palestine, in Gaza and West Bank for their marvelous job fighting COVID-19, especially the frontline healthcare providers. I also would like to thank the IUG Medical College for making such course real today through their efforts and support. Now I will give the speak to Dr. Ahmed Al-Ghazali. He's the head of medical department in IUG Medical College from Gaza, and his guest, Dr. Iyad Abu Karsh. Thank you. Go ahead, Dr. Ahmed.
شكرا دكتور محمد. بسم الله الرحمن الرحيم. السادة المحاضرون الكرام من دولة قطر، الدكتور إبراهيم فوزي والدكتور أحمد لبيب، استشاريو الأمراض الصدرية والعناية المركزة في دولة قطر، الدكتور مدير العناية المركزة في وزارة الصحة الفلسطينية الدكتور إياد أبو كرش، الزملاء في اللجنة المنظمة لهذه الدورة، والزملاء الأطباء الحضور كل باسمه ولقبه في التخصصات المختلفة. السلام عليكم ورحمة الله وبركاته. يطيب لنا في كلية الطب بالجامعة الإسلامية بغزة أن نتقدم لكم جميعا بالتحية والتقدير كل في موقعه. نشكر بشكل خاص الإخوة الأفاضل الاستشاريين في دولة قطر الذين تطوعوا مشكورين لنقل المعلومات القيمة والخبرة العملية وزبدة التجربة القطرية في التعامل مع جائحة كورونا. لهم منا كل احترام والشكر والتقدير، ومن خلفهم طبعا الجمعية القطرية للحالات الحرجة. الإخوة الكرام جميعا، لا يخفى عليكم الوضع الوبائي الحالي في قطاع غزة والأرقام اليومية المتصاعدة والمرشحة للصعود، والتوقعات بالنسبة للأيام المقبلة التي نسأل الله تعالى أن يقدر لنا فيها الخير. وانطلاقا من مسؤولية كلية الطب ودورها في التعليم الطبي المستمر، تأتي هذه الدورة وغيرها من الدورات والدبلومات المستمرة. وإن كان التركيز على هذه الدورة الهدف الأساسي لما كنا بننظم في الدورة، الهدف الأساسي هو أن يعني يكون عند الطبيب، سواء طبيب العناية المركز الجديد أو طبيب الباطنة أو طبيب الطوارئ أو التخدير، معرفة كافية بالتعامل مع أساسيات العناية المركزة وخصوصا حالات الكوفيد 19. وإن شاء الله هذه الدورة تؤتي ثمارها، بحيث أنه مخرجات الدورة تلبي هذه الطموحات، بحيث أنه معظم الأطباء الحاضرين لهذه الدورة هم حاليا أو سيكونون في المستقبل القريب هم خط الدفاع الأول في مواجهة كورونا. فنسأل الله لهم العون والتوفيق، ونسأل الله لهم الفائدة. وطبعا حرصنا أن تكون هذه الدورة بالمشاركة الكاملة مع وزارة الصحة بصفتها هي المقدم الرئيسي للخدمة الصحية والمسؤول الأول عن الخدمة الصحية في قطاع غزة. فهذه الدورة طبعا بالتنسيق مع دائرة العناية المركزة في وزارة الصحة، ويمثلها طبعا الدكتور إياد أبو كريش الذي سأقدمه إلى كلمته قبل قليل. ولا أنسى في الختام أن أشكر اللجنة المنظمة لهذه الدورة من قطر الدكتور محمد قنديل والدكتور أحمد المخللاتي، ومن غزة الدكتور بكر أبو جراد معنا. بارك الله فيكم. وأنقل كلمة افتتاحية قصيرة للدكتور إياد أبو كريش مدير وحدات العناية المركزة في وزارة الصحة الفلسطينية، وشكرا. دكتور إياد إذا معنا تفضل.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد سيد أجمعين. طبعا في ظل الظروف المحيطة العالم كان لابد من مواجهة هذا الوباء والجائحة بنوع من التكاثف العلمي وتبادل المعلومات في العالم كله. وهنا طبعا احنا بنتمثل في غزة واخوتنا موجودين في الجامعة الإسلامية وزملائاتنا اللي قاموا بهذا العمل الرائع بالتواصل معنا طبعا لتنظيم هذه المحاضرات العلمية للأطباء اللي حيشتغلوا في العناية المركزة أو الشباب اللي حابين يطوروا من قدراتهم في علم العناية المركزة أو التعامل معها. لا شك أنه كوفيد اليوم في قطاع غزة الحالات في تزايد فعلا، نوعية الحالات خلينا نقول في تزايد فعلا، يعني severity of illness for this patient they are getting worse and worse. ولكن اللي بحب أقوله أنه لولا أنه العلم كان عليه هناك ذكاء وهي منفعة الآخرين. الرسول صلى الله عليه وسلم هو أول من لقب بالمعلم، ولهذا وجب على كل من تعلم شيئا أن يعلمه. وجه بالشكر الخاص لإخوتنا في قطر محاضرين تعاونهم، هذه ليست المرة الأولى وأعرف كذلك، وأتمنى إن شاء الله، أنا متأكد أنها تكون ليست المرة الأخيرة. قد يكون هذا أول مديول مع وزارة الصحة فعلا في التعاون في هذا المجال، ونطمح للتعاون في مجالات أخرى فيما يخص العناية والتخدير أو طب الطوارئ. مشكورين زملائنا ومحاضرينا في قطر. طبعا هنا الدور الرئيسي كان المنسق اللي هو زملائنا في الجامعة الإسلامية كلهم جميعا، على رأسهم الدكتور فاضل النعيم والدكتور أحمد والدكتور محمد، كلهم مشكورين. كما توجه بالشكر لزملائي العاملين في وزارة الصحة الذين لبوا فعلا الدعوة فور تم إخبارهم بهذا، فعلا هم أشادوا أكدوا، بل أكدوا وصمموا على الحضور، وكانوا جدا هم فرحين في هذا اللقاء. لكي لا نطيل، أنا أرجو من أخوتي زملاتي أنه يكون هناك تفاعل، لأنه الأخوة المحاضرين عندهم خبرة كويسة وعندهم تجربة يعني لابد الاستفادة منها، وأنا متأكد أن هناك استفادة كبيرة، وأن يكون هناك مشاركة فعالة، خاصة وأن معظم الزملاء كانوا قد اجتازوا دورة من مدة أسبوع 5 أيام في العناية المركزة قامت فيها دائرة التنمية والقوى البشرية أيضا بالتعاون مع وزارة الصحة. ولكن أنا بقول دائما كل يوم نتعلم جديد، وكل يوم نتعلم فيه جديد أكيد نكتسب فيه خبرة جديدة. اليوم حيكون اخوتنا زملاتنا في قطر حيكون مور ابليكابل، يعني حاجات عمليه هم مارسوها في حياتهم حيعلموها للشباب، والشباب اكيد حيستفيد منها. وانا دائما حكون بتواصل معكم. لا يسعني في الاخر الا اتقدم بالشكر المتواضع لاخوتي وزملاتي في قطر ولاخوتي وزملاتي في الجامعه الاسلاميه، واتمنى هذا التعاون ان يستمر في مجالات اخرى كما قال. وارجو ان يكون هناك في اقتراحات كثيره من زملائي الموجودين في غزه بنقاشات، ممكن نعمل ويبينار بعد كده، كيس ستادي، اي شيء. انا متاكد ان زملائي في قطر حيرحبوا بهذه المواضيع. اعطيك الميكروفون لدكتور احمد، وعلى بركه الله ننطلق، وبسم الله الرحمن الرحيم.
شكرا دكتور إياد، الله يعطيك العافية. يا جماعة نؤكد أنه في شهادات إن شاء الله الطب للحاضرين بنسبة معينة، وطبعا إدارة الدورة الآن بنقولها للدكتور محمد من قطر. تفضل دكتور محمد.
شكرا دكتور أحمد. Now we'll start with Dr. Ibrahim Fawzi. He will start with the first lecture إن شاء الله. Go ahead دكتور إبراهيم.
السلام عليكم ورحمة الله وبركاته. والله جزاكم الله خير على التحضير للموضوع ده مهم جدا طبعا. ودكتور محمد قنديل يعني ما قصر صراحة، جمع كل الأطباء من قطر عشان يحطوا كل all their effort. فنبعت لكم سلام يا أهل الرباط، أنتم في رباط إلى يوم الدين، وإحنا نتشرف، لينا شرف إن نتشارك معاكم بعض المعلومات اللي سبحان الله ربنا أنعم علينا فيها. فماي فوكس today هنتكلم عن ال respiratory failure، ونتكلم عن conventional ventilation. What should we do if you face someone with severe respiratory failure? بسم الله الرحمن الرحيم. شوف كده. طيب أنا I have no conflict of interest، والobjective of the talk اللي هنركز فيها هيكون على definition of severe respiratory failure, management and diagnostic approach to ARDS. هنتكلم عن الجاز exchange and oxygen transport and pulmonary circulation، لأنها ليها علاقة، it's all connected to each other. فإحنا will try to make it in a simple way to understand all this complex pathophysiology. We'll focus in protective lung ventilation, and I think this is really the most important piece that people need to understand, how to apply protective lung ventilation. 80 to 90% of patients only will respond to this, يعني سواء COVID or non-COVID. It's very important to apply this very well. Then we'll talk about bronch position and very briefly about the role of ECMO in ARDS. ARDS defined as acute respiratory distress syndrome. عنده طبعا so many names: acute lung injury, other respiratory distress syndrome, or shock lung. It's a severe life-threatening medical condition, usually characterized by widespread inflammation in the lung and associated with severe hypoxemia and stiff, very stiff lung. And have various definitions. It have to be acute onset. Most of the cases we see طبعا بيكونوا at the moment is corona طبعا COVID. Before that can many different causes of it. And it have to usually come with normal heart, لأن pulmonary edema and cardiogenic pulmonary edema can mimic ARDS, and the treatment of both of them is a bit different. في terminology بنستعملها اسمها PF ratio اللي هي fraction between the partial pressure of oxygen and the FiO2 that we use. فأنت if you take a normal person and you do a blood gas on him in room air, the FiO2 concentration is 21%. A normal person will have a PO2 of around 100, close to 100 حسب العمر طبعا and the lung mechanics. But if it's a normal lung, will be 100. فالnormal PF ratio تقريبا between 400 and 500. If the hypoxemia is severe and the PF ratio less than 300 with bilateral pulmonary infiltrate, you are talking about ARDS. And based on that, we'll go about the criteria in a few minutes, about the criteria based on the PF ratio. So etiology, you can have many reasons for ARDS. Infection is the most common, bacterial pneumonia, streptococcal, staph, Klebsiella, all sorts of Pseudomonas, viral pneumonia, COVID, non-COVID, influenza, and so many others. There is inflammatory pneumonitis, alveolar hemorrhage, the acute idiopathic pneumonitis, the lupus pneumonitis. You can have sepsis, you can have extrapulmonary causes of ARDS. You can have trauma, inhalation injury, acute pancreatitis, burn, chemical pneumonitis, and so many other causes for the ARDS. Diagnostic consideration, usually if you have someone coming with that, lots of sampling, starting from imaging study, X-ray, CT scan, sometimes lung ultrasound can help to look for the consolidation of the lung. Most of the time we need an airway sample, suction through the airway if patient is intubated already, or bronchoscopy, to define what type of infection. Is it COVID? Is it non-COVID? Is it pulmonary hemorrhage? Very rare we will need biopsy. Most of the time you will have a systemic effect, so you have a CBC, complete blood count, look for differential, we look for eosinophilia, with blood cultures to make sure there is no bacterial infection or fungal, and so many other tests. And obviously cardiac assessment is important, and the echo usually is the best non-invasive step for diagnosis. The disease as COVID as well as affect pretty much all ages from adult group. The more the age, the mortality usually goes higher as well. And the treatment usually supportive, but we have targeted therapy. So if you have a bacteria, you treat. If you have viral pneumonia and you have antiviral, you can use. If it's inflammatory pneumonitis, you have to treat that as well, and so on. So, but the most really crucial part on the management, if they are very hypoxemic, is to support their oxygenation with a proper ventilation. So if you decided to intubate, you have to know what are you doing. So this is very important table to remember. Berlin definition. It's a classification of ARDS based on the PF ratio. So, and it's the last line here. Sorry. So mild ARDS is usually PF ratio between 200 and 300. Moderate is between 100 and 200. The more severe one is the PF ratio less than 100. Those are the patients who don't do very well, and their mortality is usually much higher. And these are the supportive option for oxygenation. If patient is very hypoxemic, based on the categories, start from low tidal volume ventilation, PEEP optimization. Some patients actually will do very well with only non-invasive ventilation, like high flow nasal cannula or CPAP, or just oxygen mask. But some will require mechanical ventilation, and then you will have neuromuscular blockade, bronchoposition. High frequent oscillation is usually not used anymore in adult. Lots of negative trial. And there is a device called ECHO-2R, which is extracorporeal CO2 removal, and obviously ECMO. So these are usually the available option to support gas exchange in the lung. So we will talk about some of them. Low tidal volume ventilation, we'll talk about PEEP, one slide in neuromuscular blockade. Bronchoposition is, I think, crucial, because I think this is the treatment that everyone need to learn it really. And ECMO will just have 2 slides about ECMO, what it is, how does it work. So this is a normal lung. If you take a small unit, it looks like that. This is the alveoli. And if you cross section, it's lots of sockets. And these sockets, usually this is where your gas exchange usually take place. So the blood come in through the capillary. It's a very, very thin membrane. And most of us study this already in physiology. O2 comes in, CO2 comes out, and this is the most important function of the lung. Plus the lung already have so many other functions, but the gas exchange one is the most important function of the lung. And when you look to the big picture, the blood come to the right atrium, it go to the RV, to the pulmonary artery, get oxygenated, and get back to your rest of your body, bright red. This is the oxygenated blood. If you have a virus like H1N1 or coronavirus who comes in the lung and start to replicate and cause severe inflammation, the lung tissue is damaged. And it's a bit different than what usually. So if you take this alveoli now, and you make it bigger, it's now full of exudate. And if you magnify this one as well, the blood comes in, it's full of air, or full of, of exudate and dead cells and all that. And that prevent the gas exchange. That's what we call intrapulmonary shunt. So the more you have of this unit, the blood comes in, it's shunt. It doesn't get oxygenated, and that's give you hypoxemia. So the more you have of these units, let's say this is the full units, and here, for instance, 70% of them are affected. So you will have a 70% shunt fraction. This shunt fraction can be calculated. And if you give them high oxygen, it doesn't really help. So they don't respond to oxygen. And this is the concept I will try to explain. It's because oxygen is a perfusion limited gas. So I will try to explain this in a simple diagram, because I think it's important to understand oxygenation and so if you take the alveolar capillary membrane and you think about it as you have a C, you have the RBC. The oxygen molecule is very interesting. It cannot swim. So if it go to the blood, it's usually sink. Cannot. It need a support. Sorry. So it need this bolts, which is the hemoglobin. Yeah. And with this, so oxygen in the air is usually happy person. When he go to the water, he gets sink unless he has access, as I said, to the boat. When he come to the boat, he's happy again, and he can go forward without a problem. The problem with that is you have a limited capacity of the hemoglobin, and saturation of the hemoglobin is limited as well. So the more you give oxygen, not all of it will go to the rest of your tissue. So some of them will actually stay, and the more you give, they can cause toxicity. And this is what is oxygen delivery all about. So oxygen delivery is the flow of the boat. The boat cannot is not electronic boat that can just go. It needs to go with a flow, and the flow is the cardiac output. Then the number of these bolts, which is the hemoglobin, and how much of them are saturated. This is what determine your oxygen delivery to the tissue. So they go with the flow. So this is the usual point for the oxygen. If you have a shunt, these bolts of the hemoglobin will leave this area without much gas exchange because it's blocked. The alveoli is collapsed, is infected, is inflamed. So that's what we will call intrapulmonary shunt. So if you have a two part of the lung, one is open like this, and the oxygen goes in normally, this is good. The other one is not. So when they mix together, they are 50% saturated only because this part of the lung is occluded. If you give more oxygen, what's gonna happen? Here, nothing gonna happen because it's blocked. Here, you just already maintain the capacity. So all this oxygen will just be there as a free radical and cause a lot of injury. We call it free radical or oxygen-induced lung injury, and can affect other, but it's not gonna really improve the oxygenation because this part is completely blocked. So there is no response to the oxygen therapy because of that. So the only way to fix that is, what do you guys think? I will come back to that. So intrapulmonary shunt, if you look to the big picture, the blood comes in, partially get oxygenated, partially doesn't get oxygenated. So you don't have the red, bright blood that leave the LV anymore because it's a mix between oxygenated and deoxygenated blood. So in a situation like this, we need to do really one thing, not more oxygen, but we need to open this alveoli. This is what we call alveolar recruitment. And this is the whole point of mechanical ventilation is we don't want to just give oxygen. No, we want to open the alveoli carefully without affecting the other alveoli. So I will go between the balance between alveolar recruitment and to prevent overdistension or atelectasis. That's a thin balance, but the treatment really is not high oxygen, is actually alveolar recruitment. And by that, you will have more oxygen the other side, and when they will mix together, it's not going to be still the best, but it's going to be much better than just giving oxygen. I hope this concept is clear. CO2 is a bit different. CO2 is not like oxygen. It doesn't need any balls. He actually can fly, can dive, can swim in the water, in the blood. He can ride to the hemoglobin without any permission. There is no capacity for it. And it also has a very good friend in the sea, which is the albumin. So CO2 is not a perfusion limited gas. CO2 is a diffusion limited gas. So CO2 depends on the concentration of the CO2 in the alveoli. That will determine the CO2 gradient. So usually in ARDS, you don't get much CO2 retention unless you are unable to ventilate. If you are unable to ventilate, that's a problem. But if the alveoli can move in and out, CO2 will really pass through any normal alveoli. So you don't get intrapulmonary shunt for the CO2, but you get it mostly for the oxygen. So alveolar recruitment, we intubate the patient, we put them in mechanical ventilation. And to understand the mechanical ventilation, I know in the audience there is some expert in critical care and some not so experts. So I will try to make things simple for everybody, so we all learn something about that. So it's important when you apply that, you need to understand that mechanical ventilation is not without complication. It can give you complication. And I wanted to start with a heart-lung interaction briefly, because it can increase intrapulmonary vascular resistance and can precipitate right ventricular failure if is not monitored properly. And then I will go through how safe to ventilate your patient. So let's just give you a quick review of right ventricular physiology. And this is maybe can open your mind of thinking if you have someone with right ventricular dysfunction, how to improve them and help them as well, because they are so connected to the ARDS. So rule number one is we know that lung receive 100% of the cardiac output. This is very well known. Two, right ventricular cardiac output equal to the left ventricular cardiac output is the same. Number three, this is usually the shape of the right ventricle. So you can see it's something sitting next to the LV. Is a really very weak structure comparing to the left ventricle. But despite that, it's produced the same cardiac output that the LV produce. So how that's possible? So I put them like this. It's my sister, my daughter, and my son. Ahmed is the left ventricle, and Jana is the right ventricle. But both of them push the same cardiac output. So how that possible? How for her can she push the same? So there is a lot of compensation, and I will discuss that with you. Number one, the pulmonary circulation have a low pressure. It's a low resistance circulation. So that makes things easier for the RV to push the same amount of the cardiac output. Unlike the right ventricle get perfused in both diastole and systole. And if you think about it, the pressure in systole in the coronary artery is the same as your aorta, is maybe 120. But in the right ventricle is only 25. So it still can get perfused in systole. The LV pressure, LV systolic pressure is pretty much the same as a coronary systolic pressure. So there is no gradient for perfusion. So LV get perfused only in diastole, but RV get perfused in both phases. Number three, which is really important, is 30% of the energy that require for the RV to push, it just get generated from the transeptal movement of the of the left ventricle. So LV just push a bit in the RV. This generates only 30% of the energy. So LV support the RV also in the contraction in normal condition. But if you have a sudden increase in the RV, pulmonary vascular resistance, this can really affect the RV significantly. So it usually get dilated. So you see it like that. Big dilatation of the ventricle, the pressure usually is very high on it. It pushes the septum, so it loses 30% support from the LV. The pressure is high as well, so RV cannot compensate for long and can really go in severe right ventricular failure and can precipitate cardiogenic shock. And this is the usual shape if you cut the heart horizontal, you will see it as an O shape because the RV is just sitting next to the LV. In case of severe dilatation, you see the LV shape is changed to D-shaped LV. And for people who do critical care echo, this is one of the signs that we monitor on echocardiography to assess the right ventricular function. You see it's from O shape, now it's actually D shape because the septum got deviated to the left ventricle. And this is obviously can cause severe RV ischemia. This is another picture of the echo of the D-shaped LV here. That's RV severely dilated, and this is a normal right ventricle. Okay. So it's important to understand that you really don't want to increase this pulmonary vascular resistance when you intubate these patients. You need to think about that as well. So those are the factors that contribute. So hypoxemia, increased pulmonary vascular resistance, hypercarbia and acidemia will do that. But also if you don't ventilate them properly, so if you have severe atelectasis, let's say you intubate and you don't give them enough PEEP and the alveoli, the normal alveoli start to collapse, or if you distend the alveoli significantly as well, alveolar overdistension can precipitate right ventricular dysfunction as well. So let's talk about these because we'll talk more about gas exchange later. This is the relation between PVR, pulmonary vascular resistance, and lung volume. So if you ventilate if the PVR in the zone, this is perfect. Sorry, the lung volume in this phase, the PVR is low. But if you go here or here, which is atelectasis or overdistension, you will increase the pulmonary vascular resistance. So we try to ventilate in the safe window and get the lung volume in the safe window. And the reverse relationship is the pulmonary blood flow also will drop if you don't ventilate in the safe window and precipitate a right ventricular dysfunction. This is a famous gram for pressure volume loop and show you the goal of ventilation is this green area, is the safe window. You don't want to go to this red over distension of the alveoli. And we've seen a lot of patients actually that we were called to see them for ECMO with COVID, that they were ventilated in the over distension zone and they really did very poor. They start to have a CO2 retention because the alveoli cannot distend anymore. You give them very high PEEP and the alveoli is already distended, so there is no ventilation. And this is where unique in the COVID because they started to have a severe CO2 retention and we call for ECMO. What we did, we just optimized the PEEP and decreased the distension. That helped to ventilate the alveoli and decrease the CO2. On the other hand, if you don't give them the optimum PEEP, they will collapse. That we call this de-recruitment or atelectotrauma. Then they will have the severe shunt and they will have severe hypoxemia. But if you give them in this right zone, most of the patient actually will do very well. And I will tell you what we need to do objectively at the bedside. So if we don't ventilate well, we get all this sort of complication, high airway pressure, cardiovascular collapse. You can get gut ischemia, increased intra-abdominal pressure, compartment syndrome, renal failure. So you can get multi-system organ failure if you don't really ventilate well. So it's not just the COVID that killed them, it's actually mechanical ventilation can kill patients if it's not applied appropriately. So you have to get to the right zone and you need to understand a bit of pulmonary physiology to be able to do that. And it's not difficult. I think that's what we teach, and this is the way we learn as well to try to get to the safe zone. So if you look to the lung in ARDS is a heterogeneous disease. It affects the lung differently. And every patient is, subhanAllah, is unique, is different. They are not all the same. You cannot just apply everything for the same people. Each one will behave a bit differently. But if you look to the lung zone during ARDS, you'll have area of severe consolidation. You see that. You will have a normal lung, which you want to protect. You don't want this to be over descended. And you will have a potential area that can de-recruit. It can go to the full consolidation or can be a bit in the normal side. And this is the area we try to reserve and help to prevent, to recruit it so it doesn't get de-recruited. And we try to recruit part of the consolidated lung. At the same time, we want to prevent over distension of the normal alveoli. So this is really the goal for mechanical ventilation. Ventilation-induced lung injury will be over distension, atelectasis, oxygen toxicity, because we don't forget about high oxygen can also cause a lot of mortality and morbidity. So we have to be careful of that. Moving forward, so the volume, number one, we have to be careful of the volume. So this is just an example of a lung strain in ARDS. If you have a 70 kilogram patient, ideal body weight, and you apply 6 ml per kilo, this is about 420 ml. So if this patient have a lung capacity of 1,400 and you give them 420 ml, this is fine. This volume will not really give them any complication. It should be good. However, if the consolidation is getting bigger, now you're giving them 50%. If the ARDS is worse, you're giving this 420 is almost 90% of the capacity. If someone in severe ARDS and you give them this 420 is too much for them. So each lung is different and depending on how much lung volume. So 6 ml is not applied for everyone. Some people will need 4. Some people might need 3 ml per kilo of ideal body weight. And some people will tolerate 7 ml per kilo. So volume alone is not a key, and it's not just one size fit all. Everyone will have a different depend on their compliance. This is a very old study in 2000, and it's really set the stone for critical care for ARDS management, and it really show low tidal volume versus large tidal volume. And they found, obviously, the patient who get lower tidal volume have a better survival. And this is set the stage that we need to ventilate our patient with a smaller volume. I'm not gonna go much through the study per se, However, I think everyone is moving now toward the pressures, not just the volume. So pressure-induced lung injury, I think, is something you can measure. We set the volume usually 4 to 6 ml per kilo, and then we monitor the pressure carefully because each pressure will give you the picture of the lung compliance and how much you can give more or you need to decrease and give you the limitations. So let's try to understand the pressures. So to understand the pressure, you need to understand that the mechanical ventilation has two limbs. Has an inspiratory limb where when it open, it push air, right? And it have an expiratory limb. So when the ventilator need to cycle to exhalation, it will close the inspiration and it will open the exhalation port, and then the air will come out through the exhalation port, right? So this is important to understand for people who don't know. So this is when you have inspiration, pressure go in, and you expand the lung. The maximum pressure that you go there, that's called peak airway pressure, right? This is the peak airway pressure. That's the highest pressure that you can get, and it's composed of several pressures underneath. If you hold the lung open without any flow, this pressure will drop a little bit because you eliminate resistance. To have resistance, you need to have a flow. So if you inflate the lung fully, and then you put inspiratory pause, this pressure will drop a little bit. Yeah, the difference between the peak and this pressure that drop, the pressure that drop, we call it plateau pressure. So plateau pressure is the pressure that to keep the lung inflated. And the difference between the peak and the plateau pressure, this is what we call airway resistance. It's usually around 5. If it's very wide in patient with asthma, you will have a very big difference between them. Most patients with ARDS, you will have this number almost the same or a bit different between them. So it's important to know the plateau pressure. The plateau pressure is the one that we care about as one of the very important pressures. And to measure it, you need to inflate the lung and then you hit inspiratory pause for a few seconds. And then the ventilator will give you the reading and tell you the plateau pressure is 20, is 30. So that's first pressure. So when the ventilator cycle to exhalation, it will open the exhalation limb, and then the pressure in the alveoli is high. It will push the air retrospectively to the ventilator. In the valve, we can set a pressure called positive expiratory pressure. So we can set a pressure here in the ventilator. This is what we call the PEEP. A PEEP can be from 0 to 5. Normal person has a PEEP because you have a larynx. So when you breathe in, you breathe out, you don't exhale all the lung volume because you have a larynx that maintains some of the lung volume, right? When you intubate, you bypass the larynx. So you need to keep a little bit of PEEP to prevent full lung collapse, right? This PEEP can vary from person to person, and in ARDS, usually we try to titrate it to maintain the alveoli open. Now, now you remember we have a peak airway pressure. We have peak to plateau gradient. We have the plateau pressure. Plateau pressure is a composed of two pressure. First, the PEEP that you set, and the difference between the PEEP and the plateau pressure is called the driving pressure. So the importance of these, I'm gonna talk about them from a study, but you need to know what is the plateau pressure, how to measure it, what is the driving pressure, and what's the PEEP. Plateau pressure, again, to measure it, you need to inflate the lung, and you hit end inspiratory pause, end inspiration, right? And then it will give you the reading. That's the plateau pressure. PEEP, it's already measured because you set this PEEP, unless you have auto PEEP. I'm not gonna go through auto PEEP. I think so one of my colleagues will talk about that later. And then you have the PEEP. The difference between the PEEP and the plateau is the driving pressure. And this one of the very most important pressure that we also have to measure. And I will tell you what number we usually monitor to make sure things are done well. Good. And then the cycle continue with the same pressures. But these are the three important pressure. So peak airway pressure again, that composed of airway resistance and plateau pressure. Plateau pressure is composed of the driving pressure and the PEEP. Yeah, these are the important figure I think that you need to remember. Good. So lots of data came in on the importance of the pressures, Most of them came between 1998 and 2000, and they summarize all the studies. So this is where all the study that was done with a low versus high volume. And you can see there is a, sorry, I'm just gonna remove this. You see here, there is a clear mortality difference, but here there is really no mortality difference despite, different in the volume. So they said maybe it's not only the volume, the pressure also is important. Look at these two studies, big difference between the mortality, 38 versus 71, 31 versus 40%. But if you look to the other studies, they don't have as much. What they found out is the patient who had a low plateau pressure, less than 32, in this study actually did very well. They have a low mortality versus the high pressure. In the other study that didn't show any difference, they found out that all of them have a plateau pressure less than 32. So it's not only the volume. Look here, 7 versus 10, 7 versus 10, 7 versus 10, no mortality benefit. The reason is people who have a high tidal volume, in this group, their plateau pressure was actually low, with 32, which protected them. So it's not just the volume, the pressure also as important. This is another study, it's a retrospective data, and they found out that plateau pressure correlate with mortality. The more you have plateau pressure, the more you have mortality. The lower your plateau pressure, the lower your mortality. So there is no what is the safe plateau pressure, but at least 30. But lots of data actually will tell you even less than that. We should aim for 25 or 20 or less, if we can, depending how sick your patient is. But the lower the plateau pressure, the lower your mortality. And you know how to measure the plateau pressure in inspiratory pause on the ventilator. Moving forward, this is a study also on the plateau pressure and the PEEP, and the driving pressure on patient on ECMO. It's a retrospective study. And they found out that the plateau pressure, 25, and the driving pressure less than 15 was the most important predictor of survival on patients who require ECMO. So those are the very, very severe, very sick patients. So going to driving pressure, we'll just review some of the study that look for the driving pressure. And just a reminder of the same table, just for everyone to remember that. So this was study done in 2015. There is so many studies, but I just pull a couple that are helpful. And this study, they look to, these are patient, two different group of patients. Both of them have a escalating plateau pressure. Some of them have a driving pressure that is increasing every time, and some have a driving pressure that is actually stable, no change in the driving pressure. So the same plateau, but different driving pressure because the PEEP are different, yeah? What do you think their mortality? This is the way their mortality looks. Patient who has a stable driving pressure, there is no change in mortality, even their plateau actually is high. People who have an increase in the driving pressure and the plateau pressure, their mortality actually went up. So the just tell you is also, again, not just the plateau, but the driving pressure is as important as the plateau pressure. And they done the same way in a different PEEP. So they said maybe it's the PEEP. So they done the same PEEP group. But now they have a different plateau. So the people who have a stable, despite high plateau, but their driving pressure did not really increase more than 20, have no increase in mortality. Comparing to this group, these patients with a high driving pressure here, their mortality actually was higher, despite their plateau is still not high. So it's not just the PEEP, it's the driving pressure that determines. So it's important to first control your plateau, definitely less than 30, but the driving pressure is important to control it as well. In this study, they found that driving pressure of 15, we don't want to increase more than 20. We try to keep driving pressure less than 20 if we can. So this is just a summary that is actually driving pressure is as important as the plateau pressure. Another study was done on ECMO, actually found the same thing, and I don't want to go through because of the time. Sorry. So PEEP, now we go to the PEEP. So we discussed the plateau pressure, target less than 30 if we can, driving pressure less than 20 if we can, and the PEEP. PEEP is a controversial, but I think anyone who understands pulmonary physiology know exactly how important this, very important to understand the effect of the PEEP and how can we assess this at the bedside. So PEEP is something you set end expiration, it's positive end expiratory pressure, and it's pretty much keep your alveoli open. Yeah, depend how bad is your consolidation. If you set it very high, you can over distend the normal alveoli, then you will have a severe problem on ventilation. If you set it too low, it will just collapse. Some people use the ARDS table. There's a table that people give it just for people who doesn't know what to do. It works sometimes, but if patient is unique, it can kill the patient. So you have to be really careful of what you apply. And we found this very prominent in the COVID for some reason. I didn't found that as much in H1N1 and strep pneumonia, but we getting, maybe because the peak and so many patients, we got a lot of referral for CO2 retention that was just because of the PEEP was set too high. Are we going in with time? Hope so.
We have 15 minutes, Dr. Ibrahim.
Only 15 minutes, type. I will move quickly, sorry. So this is just a table example. When you set the PEEP, this alveoli is completely collapsed. This alveoli, now it's gonna be open up a little bit because you increase the PEEP. And your goal is not to over distend this alveoli, so to keep this balance. And how can you, just because of the time, I probably will just go quickly, sorry for that. It's a big lecture. I think what we need to go is how to assess your PEEP at the bedside, how to optimize the PEEP at the bedside. So there is different way to do that. Imaging study, pulmonary blood flow. The easiest one to do it is, this is recruitable lung, for instance, and this is non-recruitable lung. But I will just go through, sorry, because of the time, I'm just gonna skip some of the imaging. Maybe we can repeat that at one point, because I wanna move to prone position. So I don't have here the summary of how to optimize the PEEP. Maybe Khandil, we should give them the table for PEEP titration based on the lung compliance, because I think this is the most practical one that you can do it at the bedside without much problem. So just because of the time, I will move to prone position because we think it's also as important. So prone position is one of the rescue therapy if you fail protective lung ventilation, and it's really one of the things that really decrease mortality significantly. It have a physiology background. The most important one is if you look to this CT scan, for instance, of a patient who has a severe ARDS, I'm gonna skip the effect and the shape. I think I will go quickly to this image. So you can see in supine position, the effect of the heart, I think, is important. When you supine, when you put them in prone, the heart is actually to the back and you free all this part of the lung. So that's additional recruitment. And I think other than the lung, the heart volume effect on the lung, more important is the diaphragm. And diaphragm in this picture. So lung usually are compressed in this position when you are supine. When you go prone, you relieve the diaphragm, and this recruits significant volume in the lung. So effect of the diaphragm and the heart, I think, are the two most important that really open the alveoli and give you up to 200 ml of recruitable volume without giving PEEP or anything. So it's a natural way of doing it to do lung recruitment. This is a CT scan for patient with ARDS. When we prone them, you can see the difference. All this part actually got recruited significantly here with severe consolidation and prone position. It did open up, and the examples of this is many. This is a PROSEVA trial that did show significant mortality benefit for patient with severe ARDS, PF ratio less than 150. When they place in a prone position, they did very well. I believe there is a workshop in prone position, I think by Dr. Ali Muhammad. Did we organize that?
Yes, yes.
Okay, very good. So they will talk more about that as well. Some patient will not respond to prone position, like this patient who is very, very severely ill. And in these patients, sometimes we were required to actually do extracorporeal membrane oxygenation for them. And I'm not really going to go through ECMO is pretty much taking the blood out of the body, oxygenated and return it back. So you can do this extracorporeally with resting the lung. For some reason, my other slides are not updated. So that's why when I transfer computer, it didn't come the most recent one because I make it condense only on ECMO. So I think just the take home message is COVID, as any other ARDS, is disease that affect the lung. I think the most important part of the treatment, if they're very, very sick and they require intubation, you really need to do your protective lung ventilation, prevent overdistension, and prevent severe atelectasis. Most of the other treatments supportive, and if you do this right, I think 95 or 98 of these patients will do well, and will hopefully pass that. Some of these patients, we are not talking specifically about COVID, but given the COVID pandemic is currently running, is the unique thing that we found different than other is the association with pulmonary embolism and microthrombi. And some of these patients will require really anticoagulation. All the other drugs that are giving, there is really no evidence base. People just keep getting stuff, hydroxychloroquine and other drugs. I'm not sure that really help in the mortality. I think the most important piece of improving mortality is a very good critical care practice. And this is what we need to really condense our work on. It's a proper oxygen support and boosting their immune system. They will fight the virus, they will get it. You just need to get them past the hypoxemia and hypercarbia safely without causing vent-induced lung injury. With that, I will end my talk. I'm happy to have any questions. And I apologize if I prolong the talk more than needed.
Thank you very much, Dr. Ibrahim. We'll open the discussion now by Dr. Saber. He will start, inshallah, now. Dr. Saber, can you hear me?
Yes.
Yeah, go ahead, Dr. Saber.
Yeah. السلام عليكم ورحمة الله وبركاته. كيف الحال؟
عليكم السلام ورحمة الله وبركاته.
Dr. Ibrahim Fawzi, nice to see you virtually.
الله يحييك. صابر، السلام عليكم.
الله يحييك.
Hi brother, جزاك الله خير. الله يحييك.
كيف أمورك؟ إن شاء الله طيب.
والله تمام سعيدين برؤياك والله صابر.
الله يحييك.
الله يحييك.
Thanks for the very very informative lecture. الصراحة كانت يعني من A to Z يعني. من الاكسجينيشن والتايبس اوف اي ار دي اس وبرلين ديفينيشن وكيغالي ديفينيشن يعني ثانك يو فيري ماتش. يعني صراحه احنا وي هافينج بروبلمز عندنا في كوفيد هوسبيتال انه وي ار يعني في شويه difficulty في الديفرنشيت between the both phenotype of COVID 19 L type و H type. زي ما حضرتك بتعرف يعني ال type اللي هو يعني البيب ولا الفنتيليشن بيكون harmful among these patients. احنا كلينيكالي ممكن نفرق بينهم يعني انه بيكون early setting شويه GGOs in the CT scan in high resolution CT scan, not the regular or بنسميه ال ARDS البلدي اللي احنا كنا بنعرفه. ف how to initiate the ventilation among these patients.
طيب شوف صابر، أنا I'll tell you في ال L type and H type and all these phenotype فيها a lot of يعني I think a little bit over exaggeration, and I think a lot of world experts will agree with that. It's good for publication to say H type and L type. To me, ARDS is a heterogeneous disease, and any ARDS can behave differently, and you need to really know your patient. So whether it's more GGO, whether it's a more consolidation, if you go through the steps properly, I think you will go through it without a problem. So number one, if they require intubation, yes, you intubate. Number two is good to know the lung compliance and set the PEEP appropriately. It's very important to set the PEEP appropriately. I will share with Dr. Kandil has the table that we use to titrate up the PEEP to the best optimum PEEP based on the lung compliance, and to stick with the protective lung ventilation, because whether it's H type or L type, if you do non-protective ventilation, we know it's associated with a higher mortality. But you know, we were very excited about this H type and L type in the beginning, and then we found it really, it doesn't matter really. If you still need to do your thing, because they overlap. It's a phase of the disease. It can go from this type to this type, and depend the disease progression. But you know, and I spoke to Luigi, who done that. He's a good friend of mine. It was fascinating. It's great, but at the clinical practice, it doesn't make much difference. You know, you still need to do your protective lung ventilation. And I think setting the optimum PEEP is really important. It will save you a lot of headache in the future from over distending the lung or under distending the lung. But it's good from theory perspective, but at the bedside, I didn't find it much useful. You know, that it will really change my management at the bedside.
شكرا جزيلا دكتور إبراهيم, بارك الله فيك. Now we'll start with the second lecture with Dr. Ahmed Labib. He's a senior consultant in medical ICU. He's associate professor in anesthesiology in Weill Cornell University. So now start, Dr. Ahmed. You can share the slide.
Okay, can you see my slides?
Yes, yes.
Okay, Assalamu alaikum.
Walaikum salam.
Thank you very much for this kind invitation, and I hope you enjoy my presentation as much as you enjoyed Dr. Ibrahim's presentation. I'm a different species. Dr. Ibrahim is a pulmonologist and intensivist. I am an anesthetist, so we have a slightly different approach to things, but and also my talk is slightly different. So I'm going to talk to you about airway management of the critically ill patients, which is slightly different from the normal anesthetic standard airway management. Right. Let's see, I have no conflict of interest, and for the purpose of this, we are going to talk about the challenges of the critical airway, and by critical, it doesn't mean difficult or critical in its management, but the critically ill patient's airway, which is the typical ICU, high dependency, emergency department, any airway management outside of the operating room or theater. I'm going to touch upon what's called the NAP4. I'm not sure if you have heard the terminology NAP4 before, but it's the National Anesthesia Project, or the National Audit Project, number 4 of the Royal College of Anaesthetists and the Difficult Airway Society and the Intensive Care Society of the UK, which is the largest database about airway complications that we have had in airway history till this moment. Difficult Airway Society guidelines, a case study, and some future directives. Right, I don't know why it's doing this. Anyway, let's do that. Right, so why we talk about out of theater airway management? Why does it matter? Because when you do intubation outside the operating room and the emergency department and the medical floor, surgical floor, sometimes you have to do it in the car park. It's different from the operating room. You have several risk factors. And what we know so far as science is that the risk of death and severe brain damage is roughly 50 to 60 times higher than the typical surgical patients. You cannot compare a patient walking to the operating room to have a hernia repair or a gallbladder being removed, what we call an ASA 1 or 2, walking, talking, fully functional, to a patient with COVID-19 pneumonia or severe pneumonia or a recent MI to whom you are giving a general anesthetic in an emergency situation. You don't know about the fasting condition. You don't know about the preparedness of the patient to your anesthetic. you are not sure about your assistant, your equipment, your medication, the allergy history of the patient, the past medical history, it's totally different. It's a totally different mindset and totally different environment. So the environment is not the operating room environment when everything is immediately available. It's not the environment when the operating room can be tilted right and left, up and down. It's not the patient with, with the past medical history being taken, patient prepared, fasted, pre-medications given. The operator is different. In the operating room, you have an anesthetist with vast experience in anesthesia management, but if an intensivist with 6-month attachment of anesthesia is doing the intubation, it's totally different story. And there's more to it. The team that doing the intubation with you on the medical floor for this hypoxic, bradycardic, about to arrest patient is not the same team in theater. If you are working in theater, you run into trouble, you shout out loud, another consultant anesthetist will come running from next door within 10 seconds. But if you are doing an emergency intubation in another building, 2 o'clock in the morning, and you shout for help, who will come to help you? So that's why out of theater airway management is fraught with difficulties. It's a rare risk, and you have to think about this risk every time you go to intubate a patient for the sake of patient safety. Right, so let's talk about the environment. So the ICU rooms, as you see in this picture on the right-hand side, is not the ideal room for intubation. Most ICU rooms are small, and you don't have enough room to go around the patient to do the things that you would like to do. The ICU rooms are crowded. Once there is a situation in the ICU room, there are 7, 8, 10, 15 people. Most of them are unfortunately useless. They are standing there doing nothing, looking at you and looking at the patient and looking at the monitor and just hindering the way of the patient. There are few of them are essential, but the rooms are dysfunctional in some way compared to the OR rooms. The ICU beds are, again, compared to the operating room table, floppy. They are less flexible. They don't allow you to turn the patient into recovery position as quick as you want. They don't allow you to do the head down position if the patient is vomiting and has risk of aspiration. So there are several risks. And as you can see, this gentleman down there is intubating in a very awkward position, but sometimes you have to do it like that. What happens also in the ward, medical floor or surgical floor, whatever ward that is, or the emergency department, the environment is not the safest environment. The lighting conditions. So do you have adequate light in your ICU room? Most of us don't. The monitor, sometimes your monitor, you have it behind your back. You are intubating the patient and you would like to see the monitor, and the monitor is just right there behind you, and you have to turn around and look for the monitor. That's one example. You have the oxygen source down there on the far left, and the oxygen tube doesn't reach, and you have to bring the patient to the oxygen tube. So the environment per se is not helping in the ward or in the emergency department. And that's a responsibility for those in authority when they design the rooms to look into these issues and make sure that when we do something risky like this, the risk management and risk mitigation is taken into account. Patient, you know about it. I'm sure most of us have done intubations in emergency situation, and the patient is a big factor in this. So most of the patients who require emergency intubation have either respiratory failure or respiratory and cardiovascular failure, and this poses significant challenges. They are already hypoxic, they are already about to arrest, they are already in cardiovascular instability. The heart rate is all over the place. They have arrhythmias, the blood pressure is 60/40. You are going to give them drugs and medications that will make the blood pressure disappear. You are going to do procedures that will make them more hypoxic. They are about to arrest, and what you are going to do may actually make them go into cardiac arrest. They usually have respiratory or ventilatory insufficiency, and you are about to remove the oxygen and perform a procedure that will deprive them from oxygen maybe for half a minute or a minute. And this is again a risk factor. Most of the patients will have a reduction of the functional residual capacity, and Dr. Ibrahim has alluded to the importance of the functional residual capacity. If they have some PEEP, because they have been on CPAP or BiPAP, and you remove that machine, you lose the PEEP, you lose the functional residual capacity. And the saturation, which was just about 80, 82, within 20 seconds will be 60. And the heart rate will go down. And we all have heard that machine go like, and our heart rate goes in the opposite direction with that. We all have been there. Also amongst the risk factors and the patient factors is the aspiration risk. So all our emergency airway management patients are at risk of aspiration. Most of them, we assume they have full stomach. We don't know when was the last time they have had something to eat or drink. And even if we know, because they have critical illness, the gastric emptying is prolonged. So the normal gastric emptying time of 4 hours in a patient who have been sick is actually prolonged to 6 or 8 hours, bare minimum. And the risk of aspiration is there. And there has been a lot of debate about cricoid pressure. When you apply cricoid pressure during intubation, how long you apply it for, what's the force, and when you release or modify the cricoid pressure if intubation is difficult. And then it's not just that, but other patients also are categorized as a higher level of risk. So if somebody has an intracranial pathology, a space occupying lesion, a raised ICB, they can cone during intubation, and we have seen that. And that's why from a medical legal viewpoint, before you intubate somebody, you check the pupils. If the pupils are already fixed and dilated, that will protect you and you document that. Otherwise, if the ICB is high and you have done that with the laryngoscope and the CO2 went from 60 to 80 and the brain swells and they herniate, it's you, it's not the pathology. So you have to be aware of all this litigation and all these issues. If somebody has an MI or an acute coronary syndrome 20 minutes ago and the heart is just doing this, you have to be aware of that. If they have cardiac issue, if they have sickle cell disease, and you know the sickle cell disease and hypoxia can cause sickling. So there are higher risk patients by default on top of the other risk factors. All this has to be taken into account for the emergency intubation. Right. The personnel in the OR, you have a team. You have a technician or a practitioner. You have another anesthetist. You have maybe if you are the senior anesthetist, you have another registrar or fellow or resident working with you to support you. You have another anesthetist next door. But if you are 2 o'clock in the morning on the medical floor by yourself, your team is very limited. And maybe it's just you and the nurse. So the team is different. The technician in the OR, you know, you just look around and you look at them and they will understand. They will pass the bougie straight to you if they see that you're struggling. They will change the blade for you. They will ask you, do you want a different laryngoscopy? But if you are doing this with an RRT team, you have to be more explicit with what you want. You have to explain to them. And sometimes you ask them for something and you'll see raise the eyebrows and say, sorry, what do you mean? And that's a big difference between the personnel helping in the OR and those in the RRT team. They need good training, they need good preparation, they have to understand the language of intubation and experience, with all due respect to the intensivist, but an anesthetist who spends all their lifetime learning how to do intubation, and that's their core skill, and airway management have some privileges over us intensivists who do that on ad hoc basis. So experience plays a major role. How often we do intubation? That's also a very important risk factor. And there is the non-technical skills for intubation. So it's called another set of skills that all of us must have when we manage situations like this. So situational awareness, time management, delegation, assertiveness, decisiveness. When you say, sorry, I'm going to stop here, I will not attempt intubation anymore. I'll just keep back mask valve ventilation. I will have, no, I'm not going to do intubation for this patient. I will wait for the anesthetist. This is by no means a discrimination or a low estimation of your skills, but it means that you are aware of your limitation. You are aware of your team's limitation and that this patient can come to harm. So the non-technical skills of communication, team management, delegation, crew resource management or crisis resource management is very, very important in airway management. The NAB4, as I alluded to, it's a good reading. It's not recent. I think it has been published now for almost a decade. And it looked at what they did in the UK. They looked at all airway management in all hospitals in the UK for a whole year. So that's not easy because they looked at about few million intubations, few million airway management episodes in the UK. And they looked at the major airway complications in the UK. They published that. So take a look at it. It was published by Tim Cook and his colleagues in BGA, and it's free access now. And they looked at airway management in the OR, emergency department, ICU, and all the risk factors, all the patient risk factors, all the complications, how often, what are the common themes, etc., etc. And it's a very useful reading. And one of the most important findings from that, okay, when we do airway management in ICU, 61%, so that's 6 out of 10 events, when we have an airway complication, the result is very bad. It's either death or permanent, persistent, hypoxic, anoxic brain damage. So we have to be aware of that. And the second bad is emergency department. So when airway management goes wrong in an ICU or in ED, it leads to either death or brain damage most of the time. And that's why this is a solid finding from this major study. And compared to the anesthesia management, they occurred out of hours, which means that after 2 o'clock or 3 o'clock, after the seniors are out of the hospital, they occur during the weekends, and they were managed by doctors with less anesthetic experience and led to permanent harm. So it's no-brainer that causes are clear. And another important factor is the end-tidal CO2 or capnography usage. So one of the recommendations for every intubation that you do in the ICU or in the emergency department, you must insist to have an end-tidal CO2. It's not optional, it's a must. And if your unit, your hospital doesn't have one, you must ask for it. You should get this machine, this monitor as a priority, because this is one of the things that will save your patients and be an important safety factor. Now I'm going to talk a little bit about guidelines. And people stick to guidelines and they love guidelines and they love protocols. But as far as I'm aware, they are called guidelines. So they are there to guide you, but not to make an order for the physicians to follow. Okay, there is a difference in that. The guidelines for anesthetic management of the critically ill patients are different from the surgical patients. So if you look at the American Society of Anesthesiologists, ASA, or the Difficult Airway Society, or the French or the German Airway Anesthesia Societies, you'll have guidelines for the typical anesthetic patient, but there are few guidelines that will help us as intensivists to manage the airway. It also gives you some insights about different approaches. The main advantage to me when I follow the guidelines is the legal protection. So in case anything goes wrong and I have to go through an investigation, somebody who's not a physician, a judge, a qadi, will ask me, Doctor, why did you do that? I said, okay. The big names, the professors, published these guidelines and they said, in this situation, ideally, you should do 1, 2, and 3. And this is what I did in the best interest of the patient. So you have some legal coverage and protection by following guidelines. So that's another advantage. When you follow the guidelines, remember that you have to have within the guidelines and through the guidelines a plan. And typically you have plan A, B, C, D, or first approach, second, third, and fourth. One of the things that I've learned over years and years is that if you don't plan, you are doomed to fail. So I have, I remember 1 or 2 occasions when things went out of control. It were the circumstances that I didn't think hard about what to do. And it seems that very easy that I don't have to think or have a plan. And these are the situations when very poor. And remember, a plan is not an equipment. A plan is not a gyroscope. A plan is not the front of the neck. A plan is not a device. A plan is not an anesthetist coming from next door. No, a plan has components to it, has equipment, has personnel, has steps, has timing to it. It's more than just a tool. Okay, so this is the tracheal intubation of critically ill patients. So this is an important source or resource, and it's freely accessible. And this flow chart should be printed out, laminated, and kept in your ICU or next to your bed trolleys, patients. And this is the brainchild of the Royal College of Anesthetists, the Intensive Care Medicine faculty, the Intensive Care Society, and the Difficult Airway Society. And as you see, it's different from the standard guidelines. And it goes through the usual plans. And simply, it has your plan A, which is tracheal intubation. Plan B and C are combined together, which is about rescue oxygenation. And if that doesn't work, you go straight to the phono or front of the neck. And here the phono is a scalpel, 4 steps cricothyroidotomy. It's not fanning, it's not inventing, it's not messing around, it's not a needle cricothyrotomy, it's just a scalpel cricothyroidotomy. It's very simple. So the advantage of this is that it's pretty standard and straightforward, and it doesn't allow you much room to play around or invent funny things. It's simple. So laryngoscopy, maximum 3 attempts. If you try rescue oxygenation, it's also maximum 3 attempts each, with either a supraglottic airway or back valve mask ventilation. And there is a lot of emphasis on the supraglottic airways. Again, if you don't have that in your airway trolley, you must have that in your airway trolley. And I'll come to the airway trolley about that. And what's very important here is this on the right-hand side: stop, think, and communicate. This box on the right-hand side doesn't exist in the normal or the regular guidelines. And it's here because the critically ill patient is different from the normal patient. And it says here, stop, think, and communicate, and you have options. You can wake the patient if this is planned, which is very rare in the hypoxic, anoxic, about to arrest patient. Wait for expert, intubate via the supraglottic or front of the neck. You can do the front of the neck here. You can also do the front of the neck early during laryngoscopy, because here, get the front of the neck airway set. So if you put your laryngoscope in and it looks very, very difficult intubation, you ask for the front of the neck set. You don't wait for 7, 8, 10 minutes and you get the front of the neck set. You have it ready by then. It doesn't mean that you will use it, but you will have it ready. And having this mental preparation to do the front of the neck access in order is an important step. It's like breaking the barrier between your brain and performing the procedure. Okay. I'll jump to plan D, and plan D is the scalpel cricothyroidotomy. And as I said, what you need for that is very simple. It's immediately available. You need a blade or a knife or a scalpel, and you need a bougie and a tube, a cuffed tube. So that's not a specific kit. It's not a branded kit. It's not something expensive and fancy. And what we have in our airway trolley is a simple clear plastic bag. It has the 3 components in it, and a special drawer, which I'm going to show you, the drawer D. And it's clear that when I say open the drawer D, what I need from that, I need that clear plastic bag immediately at the patient's bellow next to me. Okay. This was published in the BGA in 2018. So take a look at that and read it. This is again the same slide. Sorry for the application. So practically speaking, so this is your practical approach. What you need to do as a clinician doing intubation regularly, you have to prepare physically, mentally, and equipment, and scientifically. You have to practice a lot. You have to rehearse your plans with your team. If you don't have enough patients, if your center is not busy, your hospital doesn't have enough intubations, you have to do simulation. And when you face with problem, you call for help early. You call for help within the first minutes of trouble, not after 10 minutes of attempting intubation. So let's talk about preparation. So talk about preparation. Preparation includes preparation of 4 things. First, you prepare your patient. Second, equipment. Third, team, and always prepare for difficulty. It doesn't go in order like this. You finish this and then that and then this last. They are all in parallel, simultaneously. So you prepare your patients as We will go through. The patient is the first section. What you need is as stable a patient as it could be before you intubate them. Sometimes it's impossible. Sometimes the patient has severe ARDS and the saturation is 80, and whatever you do, you have been waiting for 15 minutes, you have given them BiPAP, 20/10, 100% oxygen, you have given them Lasix, and the saturation is 80 and the VO2 is 40. And you have to intubate. But this is preparation. You have done your preparation. You have to do it. So this is called pre-intubation resuscitation. You make sure that your patient is in the best possible shape to intubate without delaying the intubation, without rushing into the intubation and causing damage. You have to have good access, at least one patent green cannula, if not two. You have a fluid bolus ready and running, 250 of a crystalloid or a colloid. You have some bristors ready. This could be ephedrine, phenylephrine, metformin, or adrenaline, diluted adrenaline. You make sure that your oxygen is up and running, well connected, the patient is very well pre-oxygenated. You optimize the position and you anticipate for difficulty. Right, so difficulty is multi-levels. It's like going from first floor to the 17th floor. So people look at difficult airway and they can amalgamate all these terminologies together. Sometimes it's just difficult to maintain the airway open. You cannot maintain this airway open. So simply, you put a Guedel airway or a nasopharyngeal airway and the difficulty is over. Difficult to back valve mask ventilate. Huge beard or jaw or a big obese man and the face is as big as that, or a burn, and you try to back valve mask ventilate, the mask doesn't fit, a big leak, and that's difficulty. And you have to think about an alternative. Difficult to ventilate, again related to the shape of the face, the neck, the tongue, and maintaining the airway open. So you can have, you maintain the airway open, you do back valve mask ventilation, but you cannot remove the CO2, you cannot see the chest rising up and down, so this is difficulty to ventilate. You can be difficult to oxygenate, typically the ARDS. So the airway is open, it's easy, you do the bag, the chest is rising up and down, it's very lovely, but there is a big shunt. You cannot oxygenate. Then there is the cannot intubate, cannot ventilate, and the cannot intubate, cannot oxygenate. Okay, so there is different, and there is the final one, which I didn't include, which is cannot intubate, cannot oxygenate, cannot access the front of the neck, which is the nightmare. So there are several levels of difficulty, and this depends on your examination, your assessment, and the level of difficulty will dictate your plan of action and your approach. How we assess the difficulty, so there are several methods for doing that. So one of them is the Lemon Assess method, which is, you know, the acronym or the abbreviations. So you look externally for any facial trauma, evaluate the incisors, you put your fingers there between the incisors, the thyrohyoid, thyromental distance, the Malambati score, the obstruction, the neck mobility. There is Al-Ganzouri score there. He was an Egyptian anesthetist by background. He lived in North America and he has this validated score. It's a very nice and one of the most robust assessment tools for standard anesthetic practice. So it doesn't apply to the critically ill patient that much, but again, it's similar to most of the scoring systems that we have at the moment. The one that has a lot of application in our ICU patient is the Macoca score. And the funny thing is every time I read about the Macoca score and it says, if it's more than 2, predict difficult airway. And I was looking, you know, at this and by default, non-anesthesia intubator, you get 1, coma, you get 1, and this is our ICU patients. So all our patients, according to the Macoca score, are difficult intubation. Just 2 factors that unfortunately exist in almost, you know, 90% of our patients. And we cannot assess the mouth opening if they are in coma. We cannot assess the cervical spine movement, Malambati if they are lying in bed and they are snoring and they have, you know, a high CO2. So who is not a difficult intubation as per this validated score in the ICU? It's very hard to say, you know, none, but I think none of them is not that difficult. Before you start, you have to optimize the position. So now when I do intubations, I teach, I instruct the juniors, whatever I do, I said always have a head up 30 to 40 degrees. We know the important element of that, at least for the functional residual capacity, at least for the impact of gravity on the gastric contents and the risk of aspiration, at least for the impact of that on the lung expansion and the diaphragm going down, lots of benefits for that, but also for the ease of intubation and delay of desaturation. What we would like to do is this sniffing the morning air position. And as you know, we have this oropharyngeal laryngeal axis. We have 3 axes. And when you apply your laryngoscope, what you would like to do is to align the 3 axes as much as possible. You'll be looking from here and you'd like to see that larynx just before your eyes. What ideally you would like to do is to have the tube like this in your hand and you drop it, it goes into the larynx. That's the easiest way. So having the head extension and the neck flexion, having this below there and doing this, the extension and flexion will help you to have an easier intubation. Okay, and this is again a cartoon that depicts that anesthetist standing there, and here's your trachea lying there, laryngoscope in place, and what would you like by having this pillow, okay, and elevation of the occiput of the patient a little bit. You don't overdo that. If you do it too much, you will obstruct the airway. So there's a fine balance in doing that. Right, we see more and more of this. Most of the countries now will have an obesity and morbid obesity in the order of 25 to 40% of the population. And these, by definition, the BMI of more than 30 are difficult intubation, difficult ventilation, difficult, you name it. Difficult IV access, difficult equipment, difficult to position, difficult to transport, difficult surgery, they are difficult. So one of the things to make your life a little bit easier is called the RAM position. So there are some fancy bellows or equipment that you can buy. One of them is called the Oxford bellow, but we don't have to have that. We just have lots of blankets and sheets. And the idea is you bring the tragus of the air here to the level of the suprasternal notch and the xiphoid process. Okay, if you have this line there, you bring the larynx. Instead of going like this very deep, you have the larynx just at the level of your eyesight as you put the laryngoscope in. So always ensure, even for less obese patient, this was found to make your life easier. The tragus of the ear and the suprasternal or xiphoid process at the same level. Okay, use your pillows and use your blankets. And this is again another cartoon showing that. Right, pre-oxygenation. In other terms, denitrogenation, we know that. 21% oxygen, 79% nitrogen. And how to monitor that, how I make sure that my pre-oxygenation is effective. It's not about measuring the FiO2 because that's easy, but it's about the expired O2. So if you have a monitor in place that measures the expired O2 and you see that approaching 97, 98%, it means that your FRC is all oxygen. And then you increase your apnea time from the usual 2-3 minutes to 11 minutes, and you have a safer window for intubation. And also there are other things about the oxygen consumption, which is typically 2 to 3 ml per kilo per minute. So an average person will consume about 150. If you are pyrexial, septic, burns victim, you will consume more. Always pre-oxygenate. There is no excuse not to do pre-oxygenation. And if the patient is conscious, ask them to take 3 big deep breaths and hold them in as much as they can. And hold them. And that's the bare minimum. Otherwise, if you can use high flow nasal cannula throughout the intubation, you apply a nasal prongs or a nasal cannula throughout intubation. You apply your CPAP before intubation and nasal cannula during intubation or BiPAP. All of this will help to have a safe apnea time. The idea is to prolong your apnea time. So we talked about patient preparation, the IV access, the position, the pre-oxygenation, and the importance of all of that. It goes hand in hand that you have to have good equipment for intubation. And there are some devices that will assist you with intubation. You need some monitors, you need medications, the airway trolley, and the standardization of that across all clinical areas. That's quite important. So this is the old approach to the airway trolley. And we had this laryngoscope somewhere, face mask, LMA, airway rescue, and the other equipment. And I'm not sure if you heard about the vortex approach, but the vortex is a very interesting concept, and it divides the airway management into the safe zone or the green zone, which is the green of oxygenation. And for that, they use only 3 equipment, which is slightly different. But if you have time, just go Google or type www.vortex.com and read about that. And they have only three tools: face mask, supraglottic airway, and intubation. And 3 attempts, maximum 3 attempts to bring your patients into the green zone of safe saturation. Otherwise, you go to the CICO, cannot intubate, cannot oxygenate rescue, which is the cricothyrotomy. They don't faff around. What we are sure of is death and anoxic brain damage happens unintentionally when we insist to intubate. Because our brain tells us, you have to pass that tube between the vocal cords to save the patient. You need to pass the tube between the vocal cords to save the patient. That's the wrong message. Okay. Again, what we recommend is to have a comprehensive airway trolley. And it's like this. So in plan A, which is your intubation plan. So all of us will aim for passing the tube between the vocal cords. And for that, you detail that on the outside of the trolley. So your team knows what's outside, inside, and you're all familiar. So what you have is a Macintosh laryngoscope and some short handles for the laryngoscope. You have some CMAC blades, you have a syringe, you have lubricant, you have the tube ties, and a stylet, and that's your plan A. And if that doesn't work, you go to the second drawer, you open it immediately, and you get your supraglottic airway eye gel. It's not too many supraglottic airways. It's not a reusable, an inflatable, Supreme. It's not this brand, that brand. It's an eye gel. Only one brand, the eye gel. That's recommended, and that's the one that works in most hands. And also you have some Berman airways and some cofenylocaine and nozzles. But what's more important, if you only keep the eye gel there, that's more than adequate. In plan C, you have your face masks of all sizes or colors with Guedel and oropharyngeal, nasopharyngeal airways. That's all you need there. And then for plan D, you have the front of the neck, that clear plastic bag I told you about with the scalpel, the bougie, and the size 5 and 6 cuff tube. On top of the airway trolley, you have your screens for the awake fiber optic or for the bronchoscopy and for the direct laryngoscopy. And for the indirect laryngoscopy, this particular hospital uses the CMAC. And other hospitals, because they have money, they have the Glidoscope, they have the CMAC, they have the McGrath, they have the whatever, Ahmed Labib's equipment. So stick to one brand and familiarize yourself with it. There are about 15 different video laryngoscopes in the market. All of them are pretty similar. They are similar in 98% of the characteristics. Choose one and stick to it. On the side, you have your bougies, you have your entry catheters, you have Fruva's airways, and you have all bits and pieces, plasticky pieces that will help you with the intubation. Okay? You need some medications for intubation. You need to induce a state of hypnosis, some painkillers, muscle relaxation. You have to use adequate doses of all of that, not too much, not too little. And remember the altered pharmacokinetics and dynamics of the patient. For hypnosis, barbiturates, we never use it for ICU patients. It's historical. It has been replaced by more modern agents. Propofol will cause your blood pressure to vanish if you use propofol. My advice to all of you, don't use more than 5 mils of propofol. Only use 2 to 3 mils of propofol with some of midazolam or some ketamine. a fantastic agent called ketofol when you mix ketamine and propofol. Ketamine, dissociative anesthesia, good painkiller, good analgesia, anti-sialagogue, sympathetic stimulation. It's a good drug. Use it, or use ketamine and midazolam. Analgesia is a must. Some people will say, oh, the patient has already had a cardiac arrest, so I'm giving propofol, there is no need for analgesia. They have, you know, they are comatose, there is no need for analgesia, but analgesia is a must. And it acts synergistically with the hypnotic agent, with the midazolam. If you use 100 mics of fentanyl, you will use only 2 milligrams of midazolam, and the patient will become unconscious, and the blood pressure will not drop. It has a sparing effect of the hypnotics, and most of them are hemodynamically stable. The 2 agents that I will recommend are fentanyl and alfentanyl, and be aware of the doses and the kinetics and dynamics. Muscle relaxation, it's a must, no matter what. I always give muscle relaxants to the patient. Be aware that succinylcholine is contraindicated in patients with long stay in bed who have been spinal cord injury after 2 days of spinal cord injury, who has a burn more than 12 hours ago, any hyperkalemia, long-term dialysis patients, patients with raised ICB, succinylcholine can cause fatal cardiac arrest. And this happened personally to me when I was in my first 3 months of anesthesia residency in 1997. I had a patient with refractory hyperkalemia because of succinylcholine, with neuromuscular degenerative bedridden young man. Rocuronium is a very good agent. Use it, especially if you have the antidote to rocuronium and you know how to use it. But rocuronium is a very good agent, and be aware of the side effects and precautions. Other medications that you must have immediately to hand when you intubate somebody in the ICU or in the medical floor, you have to have some sort of suppressor, and the options are ephedrine, phenylephrine, metaraminol, adrenaline, and you may have to have atropine for bradycardia not caused by hypoxia. Bradycardia because of hypoxia, atropine is not a treatment. Cricoid pressure, you apply it using 2 fingers, usually the middle and the thumb finger. The force is exaggerated by most of us. It only has to be about 3 kilograms in weight, and the idea is to stop aspiration. If you have a patient with unstable or suspected cervical spinal injury, don't apply cricoid pressure because you can cause complete spinal cord transection. If you have a patient with esophageal problem and risk of esophageal rupture, don't use cricoid pressure because it can cause further esophageal rupture. Sometimes we do this bird maneuver, backward, upward, and rightward manipulation of the trachea and difficult intubation, and then you as the intubator, you ask the assistant to release the cricoid and you take over and you apply the cricoid. Sometimes when the airway is difficult, the cricoid can bugger off. I don't care. The risk of aspiration versus the risk of brain damage, it's obvious. So you can release the cricoid completely and focus on getting the airway secure. There are different ways of induction or different rates of induction. So this is all about RSI, rapid sequence induction, but it's not always that. So the traditional or controlled induction of anesthesia is this way: you pre-oxygenate, you sedate, and you continue to give oxygen and then paralyze. This is typical in theater. Mask of oxygen, propofol. Once the patient is asleep, asleep. Yes, he's asleep. Rocuronium or altracurium, and then intubate. There's the rapid sequence induction, which within a minute, you have to secure the airway because the patient is at very high risk of aspiration. So this is the RSI. Excuse me. So you oxygenate or pre-oxygenate and simultaneously give your combination of ketofol or midazolam, fentanyl, and paralytic, and then intubate within a minute. There is the delayed sequence induction, okay? When you try to oxygenate, the patient doesn't respond. This is typical in the ICU population, or the patient is very agitated because of hypoxia. They are doing like this, thrashing in bed. You cannot control them. You give them a little bit of ketamine, you control them, you oxygenate, and then paralyze. And take into account that this delayed sequence induction. And there is the awake intubation for the difficult airway when you give them glycopyrrolate and then you apply your oxygenation and then lidocaine and do awake intubation. So this is an example here of an ICU patient where the patient is delirious because of hypoxia, you give them ketamine, 1 to 2 milligrams per kilo, you pre-oxygenate, and then you give your paralytics, and within a minute, you secure the airway. Prepare your team, and the team composition and role, they have several tasks, and there is a lot going on. They have to work simultaneously in harmony, and sometimes we lose the sense of time, and that's why the non-technical skills are important. This gives you an illustration of how you distribute your team for the intubation and the management of the team, depending on the number of team members available. So if you have only 4, if you have 5, or if you have 6 people managing the intubation, but more importantly, when you read this, there is some consistency. So the airway equipment is always here. The first intubator is always there. The leader and the runner. So there is typically a leader, somebody standing there just watching and observing and telling the team the clock is ticking. If you cannot achieve intubation after 30 seconds, you have to move on. And that's only the role of the leader in these scenarios. Not to take over, not to jump in and say, give me the laryngoscope, I'm going to intubate, but to control the environment, to facilitate and make sure that the patient is safe. So always have a leader if you have enough manpower. In COVID-19, and this is important if you are going to intubate people with COVID-19, the image is a little bit hazy, but again, you have your intubator here. So the number of people now is only 3 inside the room, okay? Compared to here, where the bare minimum was 4, and you have somebody, first intubator, you have somebody doing the cricoid and equipment, you have somebody here, the leader, giving the medication and ready to step in for difficult intubation, and the runner will help. Here with COVID-19, you have the intubator here, the most experienced, the most skilled person has to do the intubation. So there is no room for, you do this intubation to get experience. No, this is COVID-19. The most skilled, the most experienced in the team has to step in. This is the rule, okay? And 1 assistant to do the cricoid and the equipment, the bougie, the face mask, the suction, 1 person to do the drugs and monitoring, and a runner outside the room, not inside the room, to help. How much time, Dr. Muhammad?
We have 15 minutes.
Okay, khair inshallah.
Inshallah.
Right. So again, some distribution, another cartoon to explain to you what we have in mind. So you have the primary airway operator. Say, for example, this is Dr. Muhammad. He will assure oxygenation. He will do the formal airway assessment, and he will say, my plan A, I'm going to use a size 8 tube with a Macintosh blade size 3, and I will do that within the first 3 attempts. If I fail after 3 attempts, I will go for an iGel size 4. If that doesn't work, I'll try back valve vasodilation for 3 times whilst I'm waiting for the anesthesia backup. If the patient becomes unstable, hypoxic, and I cannot control the airway with the supraglottic airway or the face mask, I need to do the front of the neck access. So this is a way of explaining and vocalizing the plans in a clear way to the team. Not too much explanation, not talking for 15 minutes, but he explains his plans and his thoughts to the team. And he will have, for example, Dr. Saber with him in the room as a backup operator. He will do examination. He will help to position the patient. He will do the external laryngeal manipulation for him and backup airway procedures. So if Dr. Muhammad is stuck here with his airway procedure and he needs some backup procedures like a burp or manipulation or something, Dr. Saber will do that, and he will step in to do the cricothyrotomy whilst Dr. Muhammad is helping with oxygenation on the top end. We have a team leader who will prepare the room and stuff and supervise and lead all this and ensure the patient is safe, and also CPR and resuscitation. This person will also help to ensure the IV medications are being given, etc., etc. Okay, monitoring includes the standards, saturation, and tidal blood pressure, ECG, etc., etc. Right, non-technical skills. So they are a collection or a constellation of skills, and most of them are cognitive. So they are more of mental skills to complement your technical skills. And one of them is situational awareness. So you are aware of what's going on. So whilst you are focusing on the airway management and holding the mask and trying to oxygenate by the back valve mask device, you are aware that the saturation has been 65 for the last 4 minutes. You are aware that you have tried 2 times to intubate and all you can see is the epiglottis. You are aware that the next help is available after 10 minutes. You are aware that none of your team is an anesthetist. So this is called situational awareness, and the patient will come to harm. So this has to be in your mind. This is situational awareness. And then you have to reach the decision making. So you have this situational awareness. You can also verbalize this. And this is something I personally do. And I do this because it helps me to ease the stress. You know, these situations are stressful. We don't have to hide it. It's painful. And we all have been there. It's stressful. So if I talk about it to my team, somebody may come up with an idea because, you know, they are standing there in the corner and they are watching everything. But doctor, we didn't do this. We haven't got that. Or actually, the Dr. X or Y is coming from theater now, or I can call, you know, something like that. So verbalize it, talk about it, and talk about clearly and loudly. Don't mumble to yourself. Then decision making. So after that, okay. And maybe Muhammad has witnessed me in some procedures, not intubation. And I said clearly, well, I'm not going to try again. We'll stop here. I think we did a big line or something that was stupidly difficult. And I said, after 4 or 5 attempts, Muhammad, it's not the day. We'll stop here. Because I kept thinking, and he can't say yes or no. But, you know, decision making, we'll stop here. Enough is enough. I don't want to expose you, the patient, or anyone to any risk. Decision making. So you speak and then you have a decision. We'll proceed. No, we have a different plan. We'll get some help. We'll abandon. We'll have to do something. Another non-technical skill is to be attentive to details and communicate your findings. So once you have found something, you have to communicate them to the rest of the team. And you have to follow simple rules. So either being goal-focused or technique-focused. So being technique-focused is sometimes harmful because you focus on, you know, getting this tube between the vocal cords and having that and watching the tidal correctly. But the goal here is to maintain life and oxygenation. So follow the simple rules of goal-focused. Maintain life, sustain life, save the patient. And if you have time, just Google this, Elaine Bromley. And it's a very interesting case about somebody who passed away because of this non-technical skills. When you have 7 or 8 senior anesthetists with about 200 years of experience and they miss simple things because they didn't have some of these skills. Right, prepare for difficulty. Before you start, sometimes you don't have time, but most of the time you have at least a minute whilst you are bring me the fluid, get the medication, are the equipment here, bring the airway trolley to rehearse with the team. Okay, have we got him in the right position or her? Be aware this man has a difficult history of intubation. Have we got the bougies? You know, rehearse with the team, speak to them. Ask yourself the question, can we wake this patient up if we fail to intubate? Always ask yourself this question. Or can I delay intubation? Can I buy time for intubation to optimize? Or can I get some extra resource if I fail? Ask yourself other questions. And speak to your team, plan A. I have a colleague, his name is Muhammad Adil. He is the best in this. He stands up and he says, plan A. And he says, plan B, plan C, etc. In a very clear way. I respect him for that. Does anyone have any comments or concerns? Ask them before you start. And ask them when you have difficulty, and ask them after you finish. And before you push in that medication, just take a big or a wide look around. Just an overview of everyone in the room, the position, the equipment, the monitor, the patient, before you commit yourself to this. Because once you start, it's very difficult to have a way back. Yeah, this is about device selection, and this was a different presentation. So video laryngoscopy in critically ill, because people ask about video laryngoscopy in critically ill patients, and it's a must or not. So a systemic review and meta-analysis done on 9 studies, 2,000 patients. The bottom line is this was published, where is the year? Can't remember. It's in Critical Care Forum by Mid Central. It's not old. I think that was published maybe 3 years ago. But the bottom line is, it doesn't perform better than traditional direct laryngoscopy across a wide range, even if they could offer better visualization. For sure, a video laryngoscopy, and these are the summary of the trials, a video laryngoscopy will convert a grade 3 intubation into a grade 2, and a grade 2B into a grade 2A or a grade 1. But that doesn't translate into a successful, a successful intubation. So one of the recommendations that, and this is from this article, and every intensivist should read this article by Higgs in BGA 2018 about the management of airway in the critically ill, that video laryngoscopies is part of life now, like COVID-19. It's not going anywhere. It's with us. It will live with us and after us. It should be available and considered as an option. And those who are involved, mean us, we should be trained in the use of video laryngoscopy. And if difficult laryngoscopy is predicted, McCook score more than 3, video laryngoscopy should be considered. It's not a must, but you should consider it from the outset. And if you are a good intubator, you have skills, and to yourself with direct laryngoscopy, this is a poor view at the first attempt, don't waste your time again with direct, go to the video laryngoscopy. So some recommendations there. The vortex approach. So this is the website, and they talk about this lifelines, and the lifelines are 3 there, and it's like a cone, or like dawama in Arabic. So the idea is your patient here in the green, and with hypoxia, the patient can succumb down and deteriorate into the blue. But with lifelines, you can bring them from the bottom, okay, up, and save them back again into the green. And this is what you are trying to do during the airway management. And the lifelines are not complex or fancy. They are not a Pentax, a very complex fiber optic device with 2 cameras and 1,500 million pixels, nothing like that. They are a face mask that all of us can use, a supraglottic airway, and an ETT. And any one of them, you are allowed only 3 attempts, a maximum of 3 attempts to bring the patient into the green zone. And the green zone is well defined by a saturation of 88 and above. And the emphasis is simple, consistent management of the airway. And if any time the patient fails those 3 lifelines, you go for the front of the neck, the FONA approach. Please take a look at the vortex. If anything that's worth reading for the airway management of critically ill, the articles by Higgs et al., BGA 2018, and the vortex approach to the airway management. What's the vortex? This is what I explained to you. So 3 techniques for airway management: oxygenation by the face mask, supraglottic airway or tube. An optimal attempt at each technique lifeline should be made with maximum 3 before moving to the next. So this is what they look at. Okay. So if you are doing the face mask and the patient is not improving, for each lifeline, you can manipulate the head and neck, you can manipulate the larynx before attempting. So for example, I'm trying to intubate and intubation is difficult. So I can optimize the position of the head and neck. I can release the cricoid pressure. I can change from a Macintosh plate 3 to a Macintosh plate 4. I can go for a McCoy, something like that, or from a direct to indirect. I can use an adjunct before attempting the next intubation. I can go for a bougie or a Fruva airway or something, change the size or the type of the tube or the airway. So all this, and the muscle relaxation also. Right. emergency airway cognitive tool, and they also apply this cognitive tool for the Vortex. It's the visual illustration of this. It's beautiful. It's done by the Australian and New Zealand Anesthesia Society. So plan A for intubation, and plan B for supraglottic, and plan C for face mask. And they are all simultaneous. It doesn't mean you get stuck to any one of them, but you can apply any of them alternatively, interchangeably at this stage. And this is that. So if you are a leader or if you are in charge of an ICU, you look at some KPIs for intubation. And the KPIs for that could be successful intubation. So how successful is your team at intubation? First attempt, how many attempts, time to tracheal intubation, the safety of the patient during intubation, and that includes complications like desaturation, cardiovascular instability, brain injury, and mortality. So you can look at those and modify them. And if there is any deviation from the standard KPIs in terms of patient safety, you can look at modifiable factors for airway management within your unit or department. And that also includes the patient, the practitioners, the drugs that are being used in the unit, the technique, and the devices. And for each one of these, there is a way to improve them. Remember your goals of airway management in the critically ill patient. You want to do oxygenation and ventilation. You would like to achieve and maintain hemodynamic stability, which means hypotension is bad, hypertension is bad, and control of the heart rate is important. Bradycardia, tachycardia, all of this, and the impact on the intracranial pressure is bad. You would like to prevent any complications, especially aspiration, pneumonia. You would like to blunt the airway reflexes like laryngospasm, bronchospasm, coughing, bucking, and hemodynamics. You would like to optimize the intubating condition by use of non-depolarizing muscle relaxant and applying some topical anesthesia for the surgical patient, but not for the ICU patient. So some take-home messages. ICU patients, emergency intubation, out-of-theater intubations, difficult airway by definition. By default, they are difficult. They are challenging. Desaturation is the norm. If they don't desaturate, they are not sick. Cardiovascular collapse happens most of the time. Blood pressure will drop, the heart rate will be altered, and cardiac arrest and brain damage is 61% incident in difficult intubation in ICU patients. 61% of airway complications lead to cardiac arrest and brain damage in ICU. Before you start, please prepare your patient, prepare your equipment, prepare your team. Prepare for difficulty and anticipate that difficulty. Have plans, not just one plan, plans. And vocalize your plans. And remember, failure to plan equals planning to fail. You are digging a hole for yourself. You must have a checklist. You must have. And this checklist, you can download it from the internet and print it and use it. It's free. You must have an airway trolley. And that airway trolley must be standardized across the hospital. So you don't have an airway trolley for theater and one for ED and one for the ICU. It's one trolley. Same colors, same drawers, same content. Have a committee or a group of experts and agree. And make it simple and standard. Because I covered this shift here today, this shift there next week. And I don't want to keep, 4 o'clock in the morning, open this drawer. No, it's not here. It's in the second drawer. No, it's in the third drawer. And this nurse never saw this. And this fellow registrar never come across that. So standardize the trolley and introduce the trolleys. Invest some time in designing and agreeing on a trolley. Training, get your people to do training, online training, virtual training, have an audit, have an M&M meeting, discuss the cases that happened, why it happened, how can we minimize them, and do simulation if you don't have enough cases. Because if we don't practice, we forget. If you are in emergency and you are stuck and it happens, call for help early and loudly. Remember, in an emergency, a tool is not a plan. Don't say, my plan is video laryngoscopy. No, that's not a plan. Use what you know and what you do best. At time of emergency, it's not the time to have a new discovery or a new invention. And don't delay the front of the neck access if you feel it's the right thing to do, because it's only 2-3 minutes and anoxic brain damage will ensue. Thank you. Questions?
Thank you very much, Dr. Ahmed. We have one question here. Which would you prefer, the intubation box or the plastic cover sheet for the COVID patient?
Well, this is an interesting question because, Mohammed, you know, we have designed this intubation plastic box and we distributed it across Hamad and other 10 hospitals we had. And then they published this paper and they showed it's useless.
Yeah.
So I'm not sure. To be honest, Wallah, I'm not sure. Whatever works best for you guys. We have had both, and I think scientifically, there is no difference. Practically, see what happens best in your hands. Because you know, with the plastic box, we have seen very limited access to the patient's airway. And sometimes, you know, as I said, the papers didn't show the risk is less with this plastic box. So from our experience, both are equally the same. We have used both. فالأرخص أحسن.
There is another question coming from Dr. Ahmed asking about the delayed sequence intubation. You can give them some tips about delayed sequence intubation.
Yeah, so in delayed sequence intubation, you have a patient who is not critically hypoxic, not with a saturation of 50, not, you know, about to arrest, but with rather a situation of 84, 85, and you know, you decide you are going to do intubation, the patient is very agitated, you cannot optimize their oxygenation, so you want to buy more time for them. So instead of, you know, putting the face mask and then doing the rapid sequence induction and then the saturation will go worse, what you can do is to give them some ketamine if you have access to ketamine. In fact, I have done this on a patient who's standing in the corner refusing anyone with IM ketamine. I give them the ketamine in the quadriceps, waiting for them to become less delirious, less agitated. And then once we got control of them, I oxygenated them properly, and then I did intubation. So this is the delayed sequence induction. It's about the sequence of your intervention. And instead of the classic intubation, sedation and paralysis together, and then intubation, no, you do some sort of sedation and then oxygenation and paralysis. And you achieve intubation with a little bit of delay.
Another question, how we can prevent cardiac arrest during intubation? What's the
few things that you can do. First, optimize your patient as much as you can. Sometimes it's inevitable. If you have, you know, a 70-year-old septic shock, blood pressure 70/30, undifferentiated shock with cardiogenic element, with 3-vessel disease beforehand, most likely they will arrest. They will just, you know, nafas, midazolam, and they will arrest. So sometimes it's inevitable, but sometimes, you know, you give them a fluid challenge, fractionated plasma protein or whatever you have as a volume, as an expander, or 250 of a crystalloid. You have a syringe of ephedrine to hand, or metaraminol or phenylephrine, something like a vasopressor to hand, and you give them 3 or 6 milligrams of ephedrine, or 50 or 100 mics of phenylephrine before you start with anything. You titrate that, you get that blood pressure from 60 or 70 to 110, 120 before you start. You give them ketamine and fentanyl, and that's it, and rocronium, and you intubate them, and you get away. You know, 50 milligrams of ketamine or 100 milligrams of ketamine and 50 of rocronium or saxamethonium if there are no contraindications, and that's it. Simple. No propofol, no midazolam, no big whacking dose of any medication. Ketamine is a very good drug. To be honest, I cannot recall having any cardiac arrest with ketamine, but I have seen a lot with propofol, on the contrary, and near arrest with propofol. And I'm not sure what's your experience with that. But propofol caused the blood pressure to almost disappear.
Is fentanyl a part of RSI or not? And what if the patient is hypotensive or having like only the sympathetic drive to hold his blood pressure? Shall we give it?
Fentanyl is a cardio-safe drug. I call it cardio-safe, or a cardiovascular safe drug. It doesn't cause significant drop of the blood pressure. it can blunt the sympathetic response, and the way of it causing drop in the blood pressure is different, because once you have no pain, your sympathetic tone will be less. On the contrary, propofol and barbiturate and midazolam, they are direct cardiorespiratory depressants. They depress the myocardium, they cause vasodilatation, and the profound effect of those on the cardiovascular system is worse compared to the fentanyl. So use fentanyl, 25 to 50 mics, it will not affect the blood pressure, even in an 8-year-old, it will not affect. And if you use that, it will translate into at least 50% reduction of the hypnosis, at least 50% reduction of the hypnosis.
I'll wait.
And it will protect the brain from any surge in the ICD.
I will wait for 30 seconds. If there is any question, then we can come to the end, inshallah. I think there is no more question. At the end, I would like to thank you, Dr. Ahmed. I'd like to thank all the audience from Palestine, and hopefully they will benefited from this lecture and Dr. Ibrahim lecture. Tomorrow, I would like to remind them that we have 2 mechanical ventilation lecture, mechanical ventilation 1 and 2. And between, we have real simulation workshop through the Hamilton ventilator online, inshallah, with one with a senior respiratory therapist here and Dr. Mohsen. Thank you, everybody.
Shukran, Dr. Mohammed. Thank you very much, everyone, and have a wonderful evening. Thank you.
Inshallah. Thank you very much.